Okay, so good morning. I am Javier Lopez. I am cardiologist at UC Davis and happy to be back here at our center, the CWP. Yay! First time back physically after, well, ... You guys know why. Anyway, but it's good to be here, and I've already, the first two questions I got so far since I got here is, is it safe? Can we come back? And so I am going to defer that discussion to the Q&A. So at the Q&A, somebody please ask that question again, and then we can kind of end at the end of the hour conversing about that if you like. I have some remarks I've prepared for today, which hopefully will take no more than 30 minutes or so. And the purpose is that we can have some conversation afterwards about anything, but specifically, I would love to talk about what it would look like if we come back physically to the program. So with that in mind, I'm going to go ahead and start my slides. Second here. So I'm assuming you can see now my slides, my first slide. And so I'm going to talk today about hypertension management. And the question I'm going to propose is for us to think about while I present to you I'm going to present one study today to you guys. And I want you to think about this question. When is it enough? When is it enough to manage your blood pressure? And so I'm going to try to address that question a little bit with some data, which is what I usually like to do, is to bring some thoughts to you and ideas to you backed up by some data. So with that in mind, that's the purpose. So remember that question at the end, let's see if we can ask ourselves, when is it enough to treat or manage hypertension? But before I get too much into this article, I just want to ask some fun questions of you. And so I like some answers from you as usually. And the first question I'm going to ask is, what is the most, thank you. I'm going to fix that. What is the most universal? Speaking, I hear that one.
Body language.
Body language, I hear that one. Anyone else?
Smiling.
Smiling, I like that one. Eye contact, I like that one. You guys have good answers. I love it. So I'm going to propose to you, is the heartbeat is the most common form of communication. And I'm going to try to prove it to you. Okay, first of all, everyone has one heartbeat, right? So not everyone has facial expression, not everyone has language, not everyone, literally everyone in the face of the earth has the things you said. You can find at least one person in the face of the earth that doesn't have one of the items you guys responded. But a heartbeat, everybody has to have. It's a definition of existence, right? It's to have a heartbeat. So I'm going to propose to you that a heartbeat is what makes us all be part of one humanity. I don't want to get too philosophical, but, just, and this is an artist's rendition of that concept. We're all, what puts us all together into a world of humanity is the one heartbeat. Anybody surprised? That sounds, yeah.
We're missing Asia.
You what?
We're missing Asia.
Asia, yeah, this is not meant to be to accuracy, a drawing of accuracy. So the heartbeat is I'm going to propose. So here's my proof to you. You look at this it's creating an image of an action, right? But everybody's heartbeat when you're sitting down, resting, your heartbeat is, in this cartoon, is 72 when you're sitting down. When you stand up, your heart rate goes up. And when you start exercising quite a bit, your heart rate goes up even further. That is, your heartbeat is communicating what it does, you know, what the message is going to carry is that you are doing exertional activity. Your cardiovascular system has been activated. That's the meaning of this form of communication. Sometimes the heartbeat is irregular and you feel palpitations. And sometimes you're short of breath or you're anxious and you feel in your chest like that. It's telling you something, right? So there are many, many different ways that your heartbeat is communicating something to us and to everyone. So it's a very informative thing. Now, how do we get from heartbeats to blood pressure? Because the heartbeat is part of the blood pressure. So if you multiply your heartbeat by the amount of blood that gets pumped in your heart at every beat, you get the cardiac output. That's what determines how much blood actually comes with every beat out of your heart is the heartbeat times the stroke volume or the amount of blood coming out. And your blood pressure is the result of this output coming out, the thickness of your blood, that has something to do with it, and the amount of blood vessel reactivity, or how much your blood vessels are, what's the tone of your blood vessels. If they're really constricted or tight, you tend to have a higher blood pressure versus you relax. So from the heartbeat, you can get to the blood pressure. And so that's my humanity pearl for today. Now, let's talk about blood pressure, which is what I really want to talk about. So this is an article that just came out a couple months ago, and to me it was very provocative because I like the idea of treating blood pressure, managing blood pressure. You know that I've been here many times talking to you about blood pressure, and the question always comes back to me, and it's always I'm limited on the information I have to answer the question, but the question usually is my blood pressure good enough? Is my blood pressure low enough? How low does my blood pressure have to be, Dr. Lopez, so I can be healthy and I can be good and I can live for a long time without having a stroke or a heart attack or something? And so most of the information we have about that is variable, and it depends on how the study was done. And so it becomes somewhat, you know, if you are European, you have a different opinion about this than if you're American. And so it varies on who actually looks at it with the number we get. And so this is why I'm limited in what to say, in the sense that I can never be totally certain of what the right number would be. And so the data from this paper may be providing us with some additional information to actually answer this question better. So I'm going to read what's in the little purple box because I know it's hard for people to see. It says, this is the commentary that came from the article. I'm going to go over the article in a minute. This is a commentary, but it starts with, receiving treatment in the United States guideline is less than 130/80. And in the European recommendations indicate achieving a blood pressure 120 to 129 over 70 to 79 for people younger than 65 years of age, and 130 to 139 for those older than 65 years. Other guidelines, as those from the UK, recommend higher target values for treatment. So it depends where you look, you get a different number, where you should be. And so if you're in the UK versus the other European countries versus the United States, and you ask the doctor will say something different, 120, 130, 140. Which one is it? Is it that different? If we're all one humanity, and we're all, the basis of our humanity is based on our heartbeats, which is, that doesn't care which language or which country we live in, why is it so hard to figure out what the damn number is, you know? And it has to do with the way the studies are done and the way the people who then analyze the data choose to analyze the data. So with that, and so the truth is that the commentary says in reality, it remains controversial. It's still controversial what the actual number is. So this study tried to address that controversy, trying to figure it out. Can we use existing data that it's out there and analyze it in such a way that we can get to try to figure out what's the low end of the blood pressure that still benefits people? So the title of the study is Pharmacological Blood Pressure Lowering for Primary and Secondary Prevention of Cardiovascular Disease across different levels of blood pressure and individual participant level data meta-analysis. It's a lot of words there. Meta-analysis means that they look at a lot of different studies. This is not a single study where they recruited everyone for the study. They looked at data that exists from multiple studies. And for this study, they looked at 48 different clinical trials that were done. And then what they did to do this is they looked in every one of these trials, people were randomized to getting a blood pressure medicine or getting a placebo. So they had data on outcomes based on whether you got the placebo, which is the sugar pill that doesn't have a benefit from the blood pressure component, and then a medication that lowers the blood pressure. And they looked on all those studies. They have people with, usually they tell you the average blood pressure is 150 something for the people in the study, but there's always a few people in the studies that have normal blood pressures, have the lower end of the blood pressure, because it's usually a distribution. It's not just always the same number. So even though they may have, 10,000 people on the study, there may be 200 people, 500 people in that study who actually had a normal blood pressure when they entered the study. This is just a reality of how these studies are done. So what these people in this meta-analysis did is they went looking for the individual data of those people with the lower blood pressures when they entered the study. And they wanted to know if you still had a lower than that 140, lower than the 130 blood pressure, and still got blood pressure medicine that lowers your blood pressure even further, did you get any benefit from that? Because that kind of challenges the question of how low do I have to start, how low do I want to bring the blood pressure? So that data existed, and they went and teased it out from these 48 clinical trials, and then they analyzed that for us, and that's what I'm going to show you today. So in review, they looked at a total of 344,000 participants over 48 randomized trials for pharmacological blood pressure lowering medication versus placebo, okay? And they say it is mostly primary prevention because they eliminated everyone who had a heart attack, and they eliminated everyone who had heart failure. So these are people that have not yet had heart attacks or heart failure. That's why this is considered to be mostly primary prevention. But people had risk factors. They had reasons, they smoked and had diabetes and other things. They just had never had a heart attack or heart failure. So the patients included in this analysis are at risk, even though they haven't had an event yet. So ultimately, they came up with 31,000 people who met this criteria. So they had risk of having cardiovascular disease, but no heart failure and no acute MI. And they were in the normal to near normal, less than 130 blood pressure. So most of your doctors may tell you that, they want to get you below 140 or below 130, depending who you are with your doctor. They went looking for the people who were started on medication below 130. Okay, that's who we're looking at. And then they asked the question, how beneficial this was to them. And here's the punchline to the study. I'm going to go all the graphs and the tables, but here's the punchline to the study. If you were 130 or less and they put you on medicine and you had a 5 millimeter reduction, so you went from average from 130 down to 125, or if you were 125, average went down to 120, or if you were 120, average went down to 115. So a 5 millimeter drop translated into this population a 10% reduction of having cardiovascular events. So even though your blood pressure was considered to be normal, being treated for a lower blood pressure, despite that being in the normal range, you still derive benefit of having a cardiovascular event. And that's the punchline of the data. This is the graphs. So the graph on the left shows the cardiovascular disease patients. So these are people who actually had cardiovascular disease. They didn't have a heart attack or heart failure, but they did have cardiovascular disease. And on the right is the data for the patients who didn't have any cardiovascular disease that were included on the study. There are two lines. There's a red line and a blue line. The blue line is the rate of events on the people on placebo. The red line is the rate of events for people that had the treatment. The blood pressure came down at least 5 millimeters of mercury. And so the lines are separated, and the red line is lower than the blue line because they had less events over time. And on the baseline is 5 years scale. So it's just looking out to 5 years. So the two lines are separating because the people who got placebo went on to have more events than the people who didn't have placebo. So that's the statistical display of the benefit of still lowering the blood pressure despite being in that benefit, in that near normal, if you will, range. So this is a little more detail here. And again, I don't know that you guys can read this. So I'm going to point out some things. I'm going to use my pen here. So this is a table that breaks down things, and they look at here at the major cardiovascular events, and then they break it up. Here's stroke. Here's ischemic heart attacks. Here's heart failure. So what they're looking at is these outcomes. What was the benefit of having the blood pressure being lower? And then down here is cardiovascular death, and this is all-cause death. Okay, so they look in 5 different outcomes. And I want you to understand how this data works. There's a line here. This is called the line of unity. And if you're to the left of the line of unity, okay, you are beneficial by having the treatment. If you're to the right of the line, the treatment actually harm you, okay? And if you notice, there is no harm. No one is on the right of the line. So for none of these treatments, treating the blood pressure was harmful. No one died more. No one had more heart failure. No one had more strokes or heart attacks if they were put on a blood pressure medicine. That's huge. It's very powerful. No one got hurt. At least no one got hurt at that level. Could you have got dizzy or lightheaded? I'm sure. Some people did get dizzy and lightheaded. Guarantee. I see it every day in my practice. But no one actually went on to have a major cardiovascular event. And so if you look here, everyone benefited. They looked at people with previous cardiovascular disease and people without cardiovascular disease. They both benefited. Same thing for heart attacks. Same thing for heart failure. When it came to death, it became, if you have previous cardiovascular disease, it was a little less of a benefit, but it was clearly beneficial, very interestingly, to the people who did not have. So this is truly primary prevention. They don't have cardiovascular disease, and if you lower their blood pressure, you reduce their cardiovascular death. And then when you look at all-cause death, meaning that not everything is not everyone dies from something related to high blood pressure, then the effect still beneficial, but it's a lot smaller. So all around, it's lowering the blood pressure benefited every group in every outcome that was looked in this study. I don't think they're all American. They're probably international studies here. I did not look at the specifics of the countries, but I'll be very surprised if they're all American. These are large clinical trials, so I'm sure some of them have to be multi-center international studies. Yeah, it's a lot of people. And so this one I found was the most profound of the data points here, is the breakdown based on what your initial blood pressure was. And again, I already told you that the line of unity here tells you, who gets harmed if you're on the right of it, and who gets benefited if you're on the left of it, right? So if you were less than 120 blood pressure, guess what? You had the largest benefit. You're the farthest away from that line. That to me was surprising. So these are the people with previous cardiovascular disease at baseline. So, and this is the most profound finding of the study. So if you had some risk factors, and even if your blood pressure was 120, if we put your medicine and we lower by at least 5 millimeters of mercury lower, you got the most benefit on having a cardiovascular event. And so when now people ask me, where should I get my blood pressure? I'm gonna say it has to get pretty down low, below 120, for me to know.
So does that mean you're gonna be treating everybody with 120?
Well, I'm showing you the data because I like to. If somebody says, well, the American Heart Association don't recommend that, and the American College of Cardiology don't recommend that, I would have to answer, they probably don't. But here's the data. You and I are seeing the data that should judge our practice. So I'm going to get to that question at the end a little bit, because I have a strategy of how I would like to do that. But in terms of medicines, giving medicines, it's really hard to say to a patient today, because based on the guidelines from the American Heart Association, ACC, it's really hard to take somebody with 118 millimeters of mercury and say, I want to start you on a medicine. In fact, somebody may think I'm a quack if I did that. But I'm showing you the data. This is just brand new data. The same this is the data on the trials that actually justify why we give you the medicine. And that same data in there is telling us that there's value to do it even at a lower levels than is recommended today. So hopefully this data is reproduced, and in the future, these guidelines will change. But in the present, this is the data that we have, the largest data set on this question that I've ever seen. The lower, the better. That's right. And when I was in Texas, in fact, one of our endocrinologists who took care of diabetic patients said we'll answer the question, the best blood pressure for my patients is the lowest blood pressure they can tolerate. He never gave a number. So if you had 120, you can tolerate 110, he said, keep going. And if you had 110 and you can tolerate 100, he said, keep going. The key there is the toleration. Can you tolerate it? Are you dizzy? Are you lightheaded?
With the lower it is?
Some people get tired, some people get dizzy, some people get lightheaded. So there's some side effects, if you will, of a lower blood pressure. And that's when you don't want to be there. You want to kind of notch it up back, allow the blood pressure to go back up a little bit once you get to that lower tolerated portion. But that's intense for the doctors and the patients to work on things. So most doctors and patients are okay with having a 130 number, a 140 number, and say, once I get just below that, I'm done. And that's how most people practice today. Once I get below the 130 or the 140, I'm done. I'm where I would need to be, right, doctor? And we just kind of nod along because we got 6 more patients to see, which probably have a blood pressure of 157.
But don't you get all kinds of readings during the day?
You do. Absolutely. So these are on the average. These are averages, not just a single reading blood pressure. That's correct.
But I've come in here and my blood pressure's been 110 and I don't notice anything as far as,
That means you can tolerate 110 just fine. And so in the average, you should try to be at 110 because that's the lowest you could tolerate. And this data will support that you can actually do an intervention. This is people who got treated for their blood pressure below 120. And they did not only well, they did better than the people with the higher blood pressures. That's what this graph shows here. So, yeah.
Can you speak, maybe not here, but eventually to where having heart failure fits to that with a lot of heart failure patients, so they can't raise their blood pressure and for them to be over.
Yeah. Yeah, that's actually why I started my first 5 minutes talking about the heart rate and how much blood you can pump and then the tone of your blood vessels, because the blood pressure gets a little complicated when you actually have a problem pumping. Heart failure is a problem with pumping blood. And so when you have a problem with pumping, like in heart failure situation, then the blood pressure management gets a little tricky and a little more complicated at that point. And so what I'm saying today is really not for patients with heart failure, because when you have heart failure, the guidelines a little different. There's a lot more parameters we watch. For example, your kidney and your brain and so your lungs. So there may be a blood pressure where you actually need a higher blood pressure rather than a lower because your kidney, for example, needs the higher blood pressure to maintain its function. So it gets more complicated. The conversation gets remarkably more complicated on the target of blood pressure for somebody with heart failure. So I want to make the distinction that today the conversation is for primary prevention, people who actually don't have heart failure and heart attacks, or people who have risk factors but haven't yet had those heart failure, heart attack events, because it gets a little bit more complicated. The other way it gets complicated with heart failure and with heart attacks is that we use blood pressure medicines for reasons that are not the blood pressure. And so we use it for what we call disease modifying. We want to change the way the heart heals and the scar forms and all these other things that have nothing to do with blood pressure. So it's sometimes good enough to give you enough medicine without the blood pressure getting too low. And so sometimes we put you on 3 blood pressure medicines, but your blood pressure is 110, and we still put you on 3 or 4 blood pressure medicines, not because we want to lower the number on the blood pressure, but because we want to change the disease itself, the way it's changing, the way the heart is healing and the way things are changing over time. So that's why it gets a little tricky to be very specific as a population for heart failure patients. It requires more individual understanding of who you are and your other issues before we can make more formal recommendations. But for a more general population without heart failure and heart attacks, this information is applicable to start looking at using lower targets for blood pressure.
So the 160 to 169 is second best on there?
Yeah. On patients with risk factors. Yeah. Yeah. I would probably say that most of these here are not that different from each other. They're close enough. This one, the 120 is the one that is kind of the broke from the pack, if you will. So you see, I can do this here. This is kind of off to the left from the pack. And that was surprising.
The 130 to 139 benefited the least.
Yep. Based on this data set, that's right. Mm-hmm. I don't have an explanation of why that little bracket is off. I don't have an explanation for that. Yeah. So in summary, this study calls for a change in clinical practice. I think the reviewers of this paper also thought so. I actually quoted that from them. It's not just my opinion, it's actually the authors of the paper. Based on this study, the decision to prescribe blood pressure medication should not be based simply on a previous diagnosis of cardiovascular. So not only for people with heart attacks and heart failure, but for people without them as well. And it should not be only based on the number 140. If you're greater than 140, then you need treatment. Less than 140, you don't need treatment. Or 130 if you're in Europe. So it should not be just the prior history of heart failure or heart attack, or just the one number metric. Rather, they propose that blood pressure medication should be viewed as an effective tool for preventing cardiovascular disease when an individual cardiovascular risk is elevated. And so there is a need to have a conversation about what is my personal risk, and if my personal risk high enough for me to actually then now want to drive my blood pressure very low, even if my blood pressure is 120.
But do you have people take their blood pressure all day long to get an average?
Yes, we do that. Yep, that's called a 24-hour ambulatory blood pressure measurement. You wear a blood pressure cuff for all day, and it pumps up every 30 minutes, and it gives me 40 numbers throughout the day, and then I can get an average. Not only I get an average, but I get a trend of how it happens, and I get to see your blood pressure at night. I get to see your blood pressure when you're walking around during the day, and I get to see the appropriate. So I had that little cartoon. When you get up and walk, your heart rate goes up and your blood pressure goes up, and that's normal. We expect the blood pressure to go up when you get up and you exercise here. I expect that your blood pressure is going to go up. So we don't want to base your medicines on that. We base your medicines on the blood pressures. Most of the day, you're not on the treadmill, you're not on the new steps. Most of the day, you're actually more sedentary and relaxed and sitting. And so we take most of the average and we look at the pattern of most of the blood pressures other than the time when you're exercising. And that's how we judge then for the medicine or the effect of the treatment. So recommendations that specify a minimum blood pressure threshold for initiation or intensification treatment, or a floor level. This is the how low do I get my blood pressure? The floor level for blood pressure reduction are not sustained by this study. So this data suggests that these are artificial numbers that we create to put in a guideline, but that it probably needs to be addressed with individual patient based on their risk. And that based on their, if they are at risk, we should be talking about lowering the blood pressure, even if you start with a blood pressure that's less than 120. And that's the point. That it's not the actual number, but it's your risk as a person. What is your risk? And when we identify you as a higher risk person, then we need to do everything we can do, including lowering your blood pressure further, regardless of the actual number. And that is what this data is telling me in our practice, what we ought to be trying to do. Now I'm going to throw my last monkey wrench into this conversation. This study is on medication, but there's nothing to say that lifestyle modifications that lower your blood pressure couldn't have the same impact. I'm going to say that again. So nothing is to say that lifestyle modifications that lower your blood pressure wouldn't have the same impact. In fact, we know that if you will do more exercise and it contributes to lowering the blood pressure, you have less cardiovascular events. And we know that if you change the way you eat, that translates in a lower blood pressure, you have fewer cardiovascular events. And we know that if you do mindful activities and meditation and other type of relaxation activities that ultimately get your blood pressure down from the daily psychosocial stress, then that also translates into having no cardiovascular disease. So there's nothing in this study that says it has to be a pill. It just says lower the number. It's really the information here is lower the number below that 120, at least by 5 millimeters of mercury. And that gives you about 10% reduction of your risk. Sounds to me like a good deal. Lower 5 millimeters of mercury, get a 10% return on it. If I told you buy this stock and you'll get a 10% return on it, darn it, you're buying it. I'm sure you would. So that's what this is. This is investment in your future health, is figure out how we can lower by 5 millimeters of mercury wherever you are, as long as you can tolerate it. Because if you're getting dizzy and lightheaded and fatigued and you can't finish the activities you want on the day, then it's too low. Let's let you got more blood pressure. In fact, you probably wouldn't guess this, but I actually prescribe salt in my practice to people who have too low blood pressure. Most of you get to hear, oh, cut down the salt because it lowers the blood pressure. That's right. But if your blood pressure gets too low, guess what I do? First, I take you off your medicine. And if your blood pressure stays too low, I recommend more water and more salt, assuming you don't have heart failure. Again, if you have heart failure, that's a complete different conversation. This does not apply to heart failure patients. So the key is to get the lowest blood pressure ultimately that you can tolerate. And that will be the benefit, the most beneficial to you based on your risk. And this study allows me to say, if you're at risk and I can get your blood pressure at least 5 points lower, I'm going to get you 10% reduction on events out to 5 years, because that's the metric that they use in the graph. So now I can say that. And I say to you, we don't need to be limited to medication. So I would say to people then, let's start with looking at what you're eating. Let's look at your physical activity. Let's look at our mindful activities. And can we get you 5 points lower with that alone? And if the answer is we can, then we don't actually have to start a medication if you're below 120. We just focus on the lifestyle modification.
How cooperative are the patients?
Well, I don't know. I'm pitching this to you. How does this sound? Have I said something that, are you sold? And this is where the discussion part of this, I'm curious what you guys think about this. This is a little, this could be considered aggressive, could be considered, you know, revolutionary, if you will. Take people with blood pressures less than 120 and start talking to them about lowering even further. I can tell you, I'm going to get a bunch of my colleagues. I'm going to raise their eyebrows and go, what is Lopez, you know, thinking today?
And Dr. Lopez, can I ask a
Yeah.
question?
Please.
This is all systolic, right?
This
I
is
was originally
systolic.
put on systolic. I was originally put on medication because my diastolic number was up to 90 and my systolic number was 120. And every study is showing the top number instead of the bottom number. I just wondered what the deal is on that.
Yeah, that's a great question. The diastolic blood pressure used to be thought to be a complete independent risk factor. And then more recent studies in the last, I would say, about 15 years now, have shown that when you look for the diastolic to stay elevated after you have treated the systolic, very rarely you find a patient that actually has a isolated high diastolic pressure. So they track very much closely. So when you lower the top number, the bottom number also comes down. When the top number goes up, in some patients, and you being at 120 over 90, you're kind of getting to that location where the lower number may be a little higher than you would have expected based on the top number. If we try to, the second thing we've learned that if we try to give people's medicines based on the lower number, we become frustrated because it's very hard to control that lower number alone. So the recommendation has been then still treat the top number, and because they track together, if you lower the top number, the bottom number will track. There are no medications just for the lower number alone. This data would suggest that if you are 120 over 90, you are still at risk because of that lower number, but that the goal should be to lower you from 120 to 115. And if you can tolerate going from 115 to 110, as long as you tolerate it, we should continue to try. Now, what's your blood pressure like now?
Runs around 108 over 68.
Yeah, there you go. So that's the proof of point here. And that when we lower your top number down, the bottom number just plunge with it. And it's no longer a distraction to the doctor, the lower number. And you got a blood pressure that is excellent in comparison to where you started when we identify your risk. And let me ask you this, and if you don't mind, put you on the spot. Are you lightheaded and dizzy with that of 106 or so?
Well, it's not always that low. Like this morning, it was 110 over 70. Once in a while, but not that often.
Yeah, and that's the experience of most people with, especially when we're treating it, that they will have a little bit of lightheadedness and dizziness here and there, especially maybe on a hot day or on a day where you haven't had enough to eat or drink, or in a day where you just basically got up really fast from wherever position you're on. Those things will trigger a small amount of lightheadedness and dizziness. As long as you know that, and most patients, as long as they know that and understand that, they are able to manage it and able to put up with it in a safe way. That's the key. It's safe, because if you're lightheaded enough that you're falling down or hurting yourself, then that's never acceptable. But if you have these very rare moments and you're safe with them and you can understand them and they don't cause anxiety, then there may be some value to accepting that, because the rest of the time you've got 106, 110, which are wonderful numbers to work with. I would say in your case, much better than the 120 or a 130 that you may have had in the past. So,
And that's without medication.
And that's without medication. That's right. We stop your medication. And so that's the power of, so that's exactly what you just described is the power of lifestyle modification. And so we lower the blood pressure by changing the lifestyle rather than the medicine. And that, I think, translates in the value for the benefit of the cardiovascular problems. Thank you for sharing that, Dave. Is there any other questions?
I have a question.
Yes, please.
So with this study, did it say anything about dietary interventions or lifestyle changes? It's just completely just based off medication.
Yes, so this is a meta-analysis where they went and pulled the data from the clinical trials where the only variable across the two groups that they tested was the placebo versus a medication. They did not test in any of these 48 clinical trials, they did not test nutrition or physical activity or mindfulness or whatnot. I'm drawing from the knowledge we have from other studies where we know that those things on their own will lower the blood pressure on their own. So exercise, if you go from not exercising to exercising, you can get somewhere in the neighborhood of 4 to 7 millimeters of mercury reduction. If you exercise and you do aerobic and resistant exercise, both, you can get almost 10 or 11 point reduction on the blood pressure. And if you go from a SAD diet, which is that means SAD means standard American diet, to a DASH diet, you get about 3 to 5 points reduction. And if you go to a full plant-based diet, it's more in the neighborhood of 10 to 12 millimeters of mercury. So we know the magnitude you get from the lifestyles. And if you combine them, if you start exercising and you put the diet together, you can get 15, 20 point reductions on your blood pressure. And again, at that point, this is where the getting lightheaded, dizzy, fatigue comes into place. And I've seen this in some of our patients who've made lifestyle changes that they actually may have done a little too much and they actually get their blood pressure low. So then we have to work about, okay, how do we make sure you have enough water, enough salt, and enough muscle mass? Because a lot of times you lose too much muscle mass with too much exercise and or dietary changes, and then the blood pressure gets low. So we have to do a medical evaluation at that point to kind of make sure that there's nothing else going on. But we can usually manage the blood pressure to come back up again to a level that's the lowest you can tolerate, which is the goal. So
So then if the AHA did adopt this, what do you think would happen for the recommendations for lifestyle and dietary changes? Do you think they'd stay the same or?
Yeah, so that's a great question. I'll get to your question in a second. That's a great question. So the recommendations from the AHA today is that the first step for the treatment of hypertension is lifestyle modification. So that's already the guidelines today. Eating healthier, exercising, and doing de-stressing activities, it's already today what's recommended. And then when you fail with those, then you add medication. That's the standard of care today, actually. So I don't think that's going to change. I think it's going to be in the range. And so based on the numbers I just said, so if a patient says to me they're going to exercise, but they're not going to change their diet, I know I'm going to get about 5 points there. And if their blood pressure is 160, in the best scenario, I'm going to get down to 152, 150. I know I'm going to need a medicine. So I may choose to start the medicine at that time with the lifestyle modification. Now, if your blood pressure is 142, and you said to me, I'm going to change my diet and exercise, then I know I can probably get down to 120 with that. And so I'm not going to start a medicine. So these are the choices I make in the office based on what the preparedness of the patient, depending how prepared you are to start making changes, I may choose to give a medicine up front. But the guideline says always start with the lifestyle before you bring the medicine on board. Does that answer your question about recommendations?
Yeah, it does. It's just interesting because I'm going to school to be a dietitian. So we're always talking about these type of things.
Excellent. We need more of you. So that's great. Hold on, Marianne. I think we had a question here.
I was asking if you made it to plant-based.
Personally,
Yeah.
I am about 80% plant-based now. Yeah. Yes, Marianne.
I had heard something about lowering blood pressure to the levels that you're talking about and its beneficial effects on the brain. And I know there's this heart-brain correlation, and I know this study was about the heart, but have you heard any of that sort of thing?
Yeah, no, that is a very good question. There is a strong correlation on lowering the blood pressure and the reduction of dementia.
Yes.
And the reason we think because there's a lot of research going on, and I think we're going to learn a lot more about this. That's why I say I think, not because I doubt what I'm going to say. We think that is due to the effect of the blood pressure on the vasculature. And the second thing we know is that about half of the cases of dementia in the United States are probably due to vasculature problems. So this is why we think it's such a beneficial thing for dementia people. So we think everyone that has dementia has Alzheimer's. Alzheimer's is just one kind of dementia, and it is not the largest, most common. We think the vascular type of dementias are actually the more common ones. And so these are people with hypertension, diabetes, and strokes who their blood vessels change and then change then the way the brain functions. Now, if you have Alzheimer's, even early Alzheimer's, and you also have hypertension, diabetes, and or strokes on top of that, then your dementia accelerates. So yes, treating the risk factors for heart conditions will slow down or improve the chances that you would not get progression of the dementia. So that is, the data is pretty good about that. There's a large study going on from the American Alzheimer's Association, and UC Davis is actually one of the centers that's funded for this, in which they're putting the treatment is to participate on a lifestyle modification program, very much like cardiac rehab and CWP. So it's dietary, stress, and exercise. And they're randomizing people to this project for that, and they're evaluating the brain progression of dementia. And so this is an ongoing 5-year, large, multi-center, ongoing study, and UC Davis is one of the centers recruiting for this.
Is that the finger study?
I think so. That sounds familiar.
Okay.
Yeah.
Okay.
Yeah.
All right. Thank you so much. I appreciate that.
I have a
Great
question.
job.
Oops, go ahead.
No, I just said great talk, Javier. That was really helpful. Beautiful
Oh, hi,
study.
Veronica.
How are you? Really good study and very, very well presented, of course, very informative. Thank you.
Thank you. I appreciate that, Veronica. It's good to see you.
Good to see you.
Dr. Lopez,
Yes.
I just have a quick question. How often should you check your blood pressure at home?
Yeah, that's a tough question to sometimes answer. I answer that question in my office, depending on who you
Not too
are.
often.
That's right, depending who you are. So I see a lot of, and as to Radhika's point, I see a lot of people that actually get very upset with their blood pressure, and in fact, it makes their blood pressure higher.
No.
So there's such a thing as too much blood pressure checking. So I'll tell you the minimum I need in my office to change your medicine. So if I get 3 blood pressures in a week, and you do it for at least 2 weeks before you come to see me, I manage your blood pressure with them as a minimum. So I don't need blood pressures every day. I don't need blood pressures 2 or 3 times a day. That to me,
Okay.
on the general, is too much.
Okay, should you do it in the morning?
Yeah,
No.
So in some, then I look at that again is specific to the patient and the medicines they're taking, whether I have it done in the morning, in the mid-morning or the mid-afternoon, or sometimes I need additional information for a patient and I may ask them to do it twice in the day or something, but that becomes very detailed about the individual patient. In general, a midday, somewhere in the midday blood pressure, 2 to 3 times a week for 2 or 3 weeks before you come to see me is good enough for me to say you're at target, or no, we need to adjust something.
Okay, thank you.
So yeah, usually after a medicine change, whenever we change any medications, or if you're sick for some reason, we ask people to check it for about a week or 2. Or if they have really high or low blood pressures, sometimes when they come to the clinic, we think maybe their blood pressures at home are fine. So we tell them to check it at home. But it's ideally, I tell people usually right before lunch, because that way you'll check it when the medicines have all gotten into your system, and we can see what the lowest blood pressure is going to be with all the medicines on board. So yeah, not too often.
Not too
Okay,
often. That's
thanks.
right.
And also when you do the 24-hour check.
Linda's asking how often we would do the 24-hour blood pressure check. We use the 24-hour blood pressure check when we are trying to establish that somebody does or does not have high blood pressure, or when we are having some difficulty being sure what the blood pressures are in relation to the medicines, or we have symptoms, we're not clear. So It's just, we do these 24-hour monitors where you wear the monitor for the entire day. And it tells us that to me is the gold standard of how well your blood pressure is managed on a daily basis. And we usually do that when we see some pattern based on what Radhika and I just described. If based on that, we're not sure, there's something that doesn't fit with what we expect based on what we hear from you and the medicines, then that's when we use the 24-hour monitor. So in practice, we don't use it that often because most of the time, the 2 to 3 times a week blood pressures for 2 to 3 weeks before you come to see us in a patient who's doing well is good enough for us to manage things. So I wanted to make sure I got a few more minutes if we could talk a little bit about coming back and how we can get us all back to doing some of these lifestyle changes, kind of back again as a community, and actually maybe even looking at our blood pressures and see how our blood pressures are doing while we've been staying away, and how our blood pressures may change when we come back. And I was wondering what the thoughts are from some of you about that. Paul likes it. Thank you.
Do you mean like a study of how the pandemic absences have affected our blood pressure, like that?
You're reading my mind, but sure, that sounds like a great idea. Yeah, something like that. So, I mean, we always work on the premise that community activities help to the de-stressing, to the psychosocial stress component, which I know that, personally and just by medical knowledge, we know that there's a remarkable high level